Hello and welcome to Medaculus. Today's topic is angina. Angina is pain or constricting discomfort in the chest, neck, shoulders, jaw, or arms caused by an insufficient blood supply to the myocardium. Angina is usually caused by coronary artery disease. Atherosclerotic plaques in the coronary arteries cause progressive narrowing of the lumen, and symptoms occur when blood flow does not provide adequate amounts of oxygen to the myocardium at times when oxygen demand increases, such as during exercise. Less commonly, angina is caused by valvular disease, for example aortic stenosis, hypertrophic obstructive cardiomyopathy, or hypertensive heart disease. Angina can be classified into three types. Stable angina usually occurs predictably with physical exertion or emotional stress, lasts for no more than 10 minutes, usually less, and is relieved within minutes of rest, as well as sublingual nitrates. Unstable angina is new-onset angina or abrupt deterioration in previously stable angina, often occurring at rest. Unstable angina usually requires immediate admission or referral to hospital. Prinzmetal angina is angina caused by vasospasm. Prognosis. Stable angina is a chronic medical condition with a low but appreciable incidence of acute coronary events and increased mortality. With appropriate lifestyle modification and medical intervention, more than half of people with angina can expect to be symptom-free within 1 year. However, some people may experience recurrence or worsening of symptoms due to progression of coronary artery disease. Important indicators of long-term prognosis include the extent and severity of coronary artery disease, left ventricular function, exercise duration or effort tolerance, and comorbidities. Complications of angina include stroke, myocardial infarction, unstable angina, sudden cardiac death, anxiety and depression, reduced quality of life. Diagnosis. Stable angina should be suspected on the basis of the clinical assessment and the typicality of chest pain. Classify the symptoms according to their typicality. People with typical angina presents with all three of the following features. Precipitated by physical exertion. Constricting discomfort in the front of the chest, in the neck, shoulders, jaw, or arms. Relieved by rest or glyceryl trinitrate, GTN, within about 5 minutes. Atypical angina presents with two of the above features. In addition, atypical symptoms include gastrointestinal discomfort and/or breathlessness and/or nausea. Factors that make a diagnosis of stable angina more likely include increasing age, male sex, the presence of cardiovascular risk factors, a history of established coronary artery disease, for example previous myocardial infarction, coronary revascularization. Factors that make a diagnosis of stable angina less likely include pain that is continuous or prolonged, pain that is unrelated to activity, pain that is brought on by breathing, pain that is associated with dizziness, palpitations, tingling, or difficulty swallowing. For people in whom stable angina cannot be excluded on the basis of the clinical assessment alone, organize a resting 12-lead ECG as soon as possible after presentation, depending on local availability. An abnormal ECG makes the diagnosis of coronary artery disease more likely, but does not confirm that the chest pain is stable angina. ECG changes that may indicate ischemia or previous myocardial infarction include pathological Q waves, left bundle branch block, ST segment and T-wave abnormalities, for example T-wave flattening or elevation, or T-wave inversion. Do not rule out stable angina on the basis of a normal resting 12-lead ECG. Do not use exercise ECG to diagnose or exclude stable angina for people without known coronary artery disease. If the person has confirmed coronary artery disease, but a diagnosis of stable angina cannot be excluded from clinical assessment, refer for diagnostic testing. Follow local protocols for management of stable angina while Waiting for the results of investigations if symptoms are typical of stable angina. Provide the person with sublingual glyceryl trinitrate to use for the relief of symptoms while they are waiting for specialist referral. Instruct the person that if they experience chest pain, they should stop what they are doing and rest. Use their glyceryl trinitrate spray or tablets as instructed. Take a second dose after 5 minutes if the pain has not eased. Call 999 for an ambulance if the pain has not eased 5 minutes after the second dose, or earlier if the pain is intensifying or the person is unwell. Consider prescribing aspirin, 75 milligrams daily, until the diagnosis is confirmed only if chest pain is considered likely to be stable angina. Advice and support. Provide information and support for people with newly diagnosed angina. Clearly explain the diagnosis of stable angina to the person. The explanation should include factors which can provoke angina, such as exertion, emotional stress, exposure to cold, or eating a large meal. Advise the person to seek medical help if there is a sudden worsening in the frequency or severity of their angina. Discuss the reasons for treatment as well as the benefits and adverse effects, such as flushing, headache, and lightheadedness. Provide information on how to use a short-acting sublingual nitrate and when to administer it. Advice about physical exertion, including sexual activity. Advice about other activities such as driving, flying, and work. Advise people that the aim of anti-anginal drug treatment is to prevent episodes of angina, and the aim of secondary prevention treatment is to prevent cardiovascular events such as heart attack and stroke. Advise about work. Many people with angina can continue to work as before. If their job involves heavy manual work, they may need to alter their work practices. If their job involves driving, they should consult the Driver and Vehicle Licensing Agency, DVLA. If the person's employer has an occupational health department, they should be encouraged to discuss any issues with them. Advice about driving. Advise the person that it is their responsibility to inform the Driver and Vehicle Licensing Agency, DVLA, of any condition that may affect their ability to drive. The DVLA's medical rules regarding angina are: for Group 1 entitlement, cars, motorcycles, driving must cease when symptoms occur at rest, with emotion, or whilst driving. Driving may recommence when satisfactory symptom control is achieved. The DVLA need not be notified. For Group 2 entitlement, lorries, buses, the person must not drive and must notify the DVLA when symptoms occur. Refusal or revocation of a driver's license may occur if symptoms, treated or untreated, continue. Relicensing may be permitted thereafter, provided that the person has been free from angina for at least 6 weeks, exercise or other functional test requirements can be met, and there is no other disqualifying condition. The person should check with their insurer to ensure that their insurance cover is appropriate with a diagnosis of angina. Advice about sexual activity. Advise the person that many people with angina continue sexual intercourse and that it is just as safe as other equally energetic forms of exercise. If sexual activity does precipitate an episode of angina, sublingual glyceryl trinitrate, GTN, taken immediately before intercourse may help prevent subsequent attacks. The concomitant use of nitrates or nicorandil with phosphodiesterase inhibitors, avanafil, sildenafil, vardenafil, and tadalafil, often used in the treatment of erectile dysfunction, is generally contraindicated. Where concurrent use is considered to be medically essential, advise people who take a phosphodiesterase inhibitor that there should be at least 12 hours between a dose of avanafil and a nitrate, 24 hours between a dose of sildenafil and a nitrate, and 48 hours between a dose of tadalafil and a nitrate. Concurrent use of nitrates and vardenafil is contraindicated. If they have an episode of angina during sexual intercourse, they must not use glyceryl trinitrate. They should stop sexual activity and, if their pain does not resolve within 10 minutes, they should call 999 for an ambulance. Advice about air travel. Give the person the following advice depending on the severity of their angina symptoms. Chest pain on considerable exertion with no recent change in symptoms or medication. No restriction on air travel. Chest pain on minimal exertion with no recent change of symptoms or medication. Consider airport assistance and possible in-flight oxygen. Chest pain at rest or a change in symptoms and/or medication. Defer travel until stable, or travel with a medical escort and ensure in-flight oxygen is available. Drug treatment for symptom relief. Prescribe sublingual glyceryl trinitrate, GTN, for the rapid relief of symptoms of angina and for use before performing activities known to cause symptoms of angina. Instruct the person that if they experience chest pain, they should stop what they are doing and rest. Use their glyceryl trinitrate spray or tablets as instructed. Take a second dose after 5 minutes if the pain has not eased. Call 999 for an ambulance if the pain has not eased 5 minutes after the second dose, or earlier if the pain is intensifying or the person is unwell. Prescribe a beta blocker or a calcium channel blocker, CCB, as first-line regular treatment to reduce the symptoms of stable angina, depending on the person's comorbidities, contraindications, and preference. If the person cannot tolerate the beta blocker or calcium channel blocker, consider switching to the other option, calcium channel blocker or beta blocker. If both beta blockers and CCBs are contraindicated or not tolerated, consider monotherapy with one of the following drugs. Decide which drug to use based on comorbidities, contraindications, the person's preference, and cost. A long-acting nitrate, such as isosorbide mononitrate, nicorandil, ivabradine, ranolazine. Review response to treatment, including any adverse effects, 2 to 4 weeks after starting or changing drug treatment. Titrate the dose against symptoms, where necessary up to the maximum licensed or tolerated dose. Drug treatment for secondary prevention. Consider antiplatelet treatment in all people with stable angina, taking into account the person's risk of bleeding and comorbidities. For most people, this will be low-dose aspirin, 75 milligrams daily. People with stroke or peripheral arterial disease should already be taking clopidogrel rather than aspirin and should continue taking clopidogrel. Consider treatment with an angiotensin-converting enzyme, ACE, inhibitor for people with stable angina and diabetes mellitus. Ensure that people with coexisting hypertension, heart failure, asymptomatic left ventricular dysfunction, chronic kidney disease, or previous myocardial infarction have been prescribed an ACE inhibitor in line with current guidance unless this is contraindicated or not tolerated. Offer a statin. Offer antihypertensive treatment. Manage a person with uncontrolled angina symptoms. People on monotherapy. Ensure that the person is taking the maximum licensed or highest tolerated dose. If the person is taking a beta blocker, switch to or add a long-acting dihydropyridine calcium channel blocker, CCB, such as amlodipine, modified-release nifedipine, or modified-release felodipine. Do not combine a beta blocker with a rate-limiting CCB, diltiazem, or verapamil, as severe bradycardia and heart failure can occur. If a dihydropyridine CCB is contraindicated or not tolerated, consider adding a nitrate, nicorandil, ivabradine. If their heart rate is 70 beats per minute or more, or ranolazine, consider seeking specialist advice when initiating ivabradine or ranolazine. If ivabradine has been initiated and the person's angina symptoms do not improve, or there is limited improvement after 3 months, seek specialist advice. Treatment is usually discontinued. If the person is taking a CCB, switch to or add a beta blocker. Do not combine a beta blocker with a rate-limiting CCB, diltiazem, or verapamil, as severe bradycardia and heart failure can occur. If a beta blocker is contraindicated or not tolerated, consider adding a nitrate, nicorandil, ivabradine, or ranolazine. Consider seeking specialist advice when initiating ivabradine or ranolazine. Do not combine ivabradine with a rate-limiting CCB because it can result in excessive bradycardia. People on dual therapy. Ensure that the person is taking the maximum licensed or highest tolerated dose of each drug. If symptom control is poor on the maximum licensed or tolerated doses of 2 drugs, refer to a cardiologist for assessment for revascularization. Consider starting a third anti-anginal drug whilst waiting for specialist assessment. Refer a person with uncontrolled angina symptoms. Consider hospital admission for people presenting with the following symptoms, as they may have unstable angina. Pain at rest, which may occur at night. Pain on minimal exertion. Angina that seems to be progressing rapidly despite increasing medical treatment. Refer to a cardiologist for angiography and possible revascularization if the person has evidence of extensive ischemia on ECG, electrocardiograph. Angina persists despite optimal drug treatment, maximum therapeutic doses of 2 drugs, and lifestyle interventions. Monitoring. Review the person every 6 months to 1 year, depending on the stability of their angina and their comorbidities. Check for ongoing symptoms of angina at rest or with exercise. Check for any complications of angina or treatment. Check the person's heart rate and blood pressure. Check for signs and symptoms of heart failure, for example, breathlessness, fatigue, or ankle swelling. Screen for low mood or depression. Review the person's medication. If the person is taking treatment for symptom control, ensure that they are taking a beta blocker or a calcium channel blocker, unless both are contraindicated or not tolerated. Ensure that the person is taking drugs for secondary prevention as appropriate. Check compliance and identify and manage drug interactions and complications of treatment. Reiterate how to use glyceryl trinitrate for rapid relief of symptoms. Managing cardiovascular risk. Manage the cardiovascular risk in a person with angina. All people with angina are assumed to be at high risk for cardiovascular events, and their cardiovascular risk factors should be managed accordingly. Optimize the management of comorbid conditions that present an increased risk of cardiovascular events, such as atrial fibrillation, chronic kidney disease, diabetes, type 1, diabetes, type 2, heart failure, chronic, hypertension, obesity, rheumatoid arthritis, and stroke and TIA. Advise and assist all people who smoke to stop. Encourage people to eat a cardioprotective diet. Do not offer vitamin or fish oil supplements to treat stable angina. Inform people that there is no evidence that they help stable angina. Offer advice and support to achieve and maintain a healthy weight to people who are overweight or obese. Encourage people to increase their physical activity levels within the limits set by their symptoms. Encourage people to limit their alcohol consumption. Advise men and women to limit their alcohol intake to 14 units a week and to spread this evenly over 3 days or more.